So to start off, we'd love to just have you introduce yourself and kind of share a little bit about your story and kind of how you ended up working with the CLA patient community.
Yeah, absolutely. So I am Bryan Sisk. I'm trained in pediatric hematology and oncology, and I take care. Most of my clinical time is taking care of patients with vascular anomalies, and and a lot of them with lymphatic malformations and then complex lymphatic anomalies. And then I spend about 25% of my time doing clinical care, and then the rest of my time is on research. And how my research went from where I initially thought I would be, in a lab injecting mice with things and developing new treatments to doing social sciences research and trying to figure out how to improve care for patients with rare diseases. So that's an interesting story of burdens that turned out to be opportunities and making sure that I remain open to all of the exciting ways that a career can turn and twist. So I'll just talk and tell you that story. So when I was starting out, I was initially wanted to do a PhD in biochemistry. My undergraduate was biochemistry, and my minors were biology and chemistry, so not very creative outside of that science mindset. And I spent about 6 or 7 years in and out of what we call wet labs, which is where you're pipetting and injecting things, and was doing really, really cool research. And when I went to medical school, I had a whole year where I was doing a research project, and we were developing a vaccine to try to prevent types of cancers in women. And it was, one of the coolest projects I could imagine. And by the end of the year, though, I realized when I was going home at night, I was thinking about ethics and thinking about communication and writing narratives. And I thought, I'm much better at this stuff than I am at pipetting things, and I have unique skills and talents here. How do I make that into a career? And so that's where I started to learn the research skills to study, communication, healthcare access, quality of life, things like that. And then I got my job, and what I so I got my job because of my research, and totally forgot to ask what I was going to be doing clinically. And my boss told me you should really think about taking care of patients with vascular anomalies. And I thought that sounds great. I've had one patient ever with these things, uh, so I jumped in and started seeing patients and learning and finding mentors and reading all the literature, and just completely fell in love with the patient population. It was people that were such strong advocates for themselves, people that have been so poorly served by our medical system, and people that um, I really felt a strong desire to kind of fill that gap in whatever way I could clinically. And so then after I started taking care of patients clinically and realizing all of the struggles they were having, all of my prior research had been in pediatric cancer. And I thought, I wonder what's been done in vascular anomalies and complex lymphatic anomalies, and found out nothing. And so then I just started going to the different advocacy groups, going to LGDA and saying, hey, believe in me. I want to do this stuff. Can you support me? And got some pilot work off the ground that has really created a nice foundation. And now we're moving into trying to improve issues with healthcare access, improve issues with communication. So that's the very long-winded way of how I got here.
Awesome. Yeah, well, that's a great story, and we are so lucky to have you advocating for our patient community. So speaking of the kind of barriers that you've seen, what are some of those barriers that you've seen to your CLA patients that you've experienced accessing care?
Absolutely. The number of patients I've had that have been misdiagnosed, have been uh, trying to find care, even if patients know what their diagnosis is, they've had insurance issues where insurance tells them you can't see that doctor, even though they are the expert in the area. Patients where they live 3, 4 hours away and they don't have the means, the money to go up and see it, or they can't take time off work. I'm doing a project now where I'm talking with primary care doctors in rural areas, and what they brought up is you really, with a lot of these patients who have limited resources in rural areas, you get one referral, and it better be the right one because they're not going to potentially have the interest or the capacity to go see a second and a third and a fourth referral. So there's a lot of patients, their first referral goes to the wrong doctor, and they say, I don't know what this is, or that's not us, and they're just kind of left hanging. And so those have been a lot of big issues. The most worrisome thing we saw from some of our research is the people that are able to routinely get to care that they need, often they have more resources, they have more income, they live in a bigger city, they live near a big center, they're younger because a lot of the experts in these areas are in pediatric hospitals, and they're just lucky. They happen to be, born in the right area. I've done interviews with people that are very wealthy, but they're in an area where there isn't an expert around. And even with their wealth and their privilege, they still don't have the easy capacity to find their way to the care. So when you say that if you want to get expert care, you have to be young, you have to have money, and you have to be lucky, that is like the perfect soup for disparity and inequity.
Yeah, definitely, definitely. Man, and my sister has been so lucky living in Atlanta, and there's a new vascular anomaly center, and she's had some really great doctors here. But now she moved to Charlotte recently, and that's a different kind of environment for healthcare. So she's, trying to figure that stuff out, which is very difficult. So I can only imagine, more rural areas for sure. But yeah, so what are you working on right now? I kind of know a little bit, but would you be willing to share more in depth?
Yeah, we've got really three projects that I think are worth talking about right now. Um, Two of them, and they all focus on how we can leverage technology to improve the care we're giving. Two of them focus really on communication, and one of them focuses on healthcare access. So the first one is called the CLA, or Lymphatic Care Companion. And so we've built a communication tool within the Epic electronic health record system. And this is what happens is if you've got a complex lymphatic anomaly and you say, I'm interested in signing up for this communication tool, we put the order into Epic, and then at timed intervals, you get a push notification that says, hey, here's a task that you can look at. And that task might be an educational thing that says, here's what your disease is. Here's your medical team. Here's what these types of doctors are. Here's what genetics means. Here's what interventions mean. We built it in collaboration, though, with families. And what families really emphasized was they also wanted stories from other patients and other families because they don't want the doom and gloom and feeling so isolated. And so we got some patient narratives and parent narratives that we incorporated in there. And then the third thing we incorporated into it is what we're calling wellness check-ins. It's essentially timed surveys that get at what families told us were really important aspects, like how's your mental health been lately? How's your pain been lately? How's the rest of your physical health been lately? Have you been able to get your medicines? Have you been having unexpected visits to the emergency department? And the other thing we learned from families is they really wanted these to be practical and actionable. They wanted their responses to lead to some type of response from the clinicians. And so we really didn't do the 5-point, 7-point Likert thing. We really said, is it better than usual, about the same as usual, or worse than usual? And then we set up triggers where anything that says things are going worse than usual, we would set up an alert, and that would send a message to the clinical team to follow up with the family. So we've launched that as a pilot study. We've got 22 people enrolled, and we've got about 6 months until they're all done participating, and we'll have the data from that. Preliminary data is people are using it, and the only people that said it has been less helpful tend to be the people that have a lot of knowledge about this and have been dealing with this for a number of years. But for the people that are newly diagnosed, it's been really, really important for them. So that's the first project. The second project we're working on relates to large language models, and specifically ChatGPT. And so a lot of this is focused on information, because some of our early studies showed that the better quality of information that families report getting about their vascular anomaly, the more likely they are to have better mental health, better physical health, and then better ability to actually navigate the healthcare system. So, our idea is that if we can find ways to improve communication for these families, we might be able to help them better support their care and better get the care they need and improve their mental and physical health. That's the goal. And so one way of improving communication is to say, well, we're going to educate the clinicians and have them better educate the families. And I think that's an important approach. But my approach has been more so thinking about the families that have the doctors that either don't have the information or don't have the ability to communicate in a way that works for the families, and how do you help those families? And so one way, we know ChatGPT exists. and we know it's freely available, and we know that some people are already using it. And so we're asking the question, for a rare disease, can we retrain ChatGPT so that it provides higher quality responses? And we're doing it through a process called retrieval augmented generation, RAG or RAG. Um, and it's a very, very complicated thing that I partially understand, but essentially we're able to create a database of knowledge that we trust. And we tell the large language model, the ChatGPT, when people ask questions, make the answers based on this data here rather than all the other data that you pulled out. And so now we are working on, we've built the first prototype of it, and we're finding that for some CLAs, we started with Gorham-Stout disease. For some complex lymphatic anomalies, it's providing better responses than the generic ChatGPT. We're expanding to the other questions. And then the biggest challenge is we want to ask like 10,000 different types of research questions. Like, do you just want to incorporate educational materials? Do you just want to incorporate review articles? Do you want to incorporate scientific articles? Is there a problem of having too few articles or having too many articles? There's lots of ways you can tinker with the pathway, the actual programming. But each of those, if we rely on one person to review it all, it'll take forever. And so the other thing that we're really working on is coming up with an automated system of evaluating the output, the responses, to see, can we figure out which responses are better? So we might, tinker 100 different things, and then we have this automated response that in, 2 seconds can give us all of these scores to pick which models are working best, rather than relying on me and 3 or 4 other people to do it, which might take, weeks or months. So that's where we've already proved the principle that it works. Now we're trying to refine the way of automatically assessing the responses. And then we want to expand it more and more and learn as much as we can about it.
Gotcha. That's very cool.
And then the third project is called VACCESS, or Vascular Anomalies Access Program. And this program is aiming to be a web-based set of resources to help patients and families and clinicians who are navigating, coordinating the care for patients with vascular anomalies. And our first step is going to actually be targeting primary care doctors. And so we have some ideas. We're about to start building it, but we've got all the funding for it. And LGDA contributed to some of that funding. The idea is that if you're a primary care doctor and you've got a patient that comes in and you think they have some type of a lymphatic anomaly, or you think they have some type of a vascular anomaly, you can go to this website and there'll be a couple of things there for you. One is you can securely type in questions, upload photographs, and have a core group of experts give you thoughts and guidance on what workup you might need to do, what tests you might need to do, and where you can refer and how to refer. The second is we've already, through some of our earlier research, developed a database of all of the vascular anomaly experts around the country. And so we can help these primary care doctors figure out who is closest to them and how to refer to those facilities. The third is we'll create educational materials, both educational materials that the clinician can hand to families, but also educational materials for that clinician that gives them the bullet points they need to help understand this set of diseases better. And then the last is creating this network of clinicians across the country who can then collaborate more cohesively with each other, and who we could then, if we needed to, have them talk one-on-one with primary care doctors. So that's our idea for the kind of first phase iteration. As we build onto it with more and more complexity, we might incorporate telehealth into it. We might incorporate AI and chatbots, but we're just trying to prove the principle that we can build something useful to start with.
Gotcha. That's awesome. Creating more access is definitely key, especially for such a rare disease. So I did also want to ask, beyond your awesome work that you're doing right now, are there any other recent advancements in the CLA research that you're pretty excited about? Anything that you think is really promising? Anything like that?
What I'm really excited about in the CLA world is better understanding how to use targeted inhibitors in medicines that can help some of these patients. Like, we know that some of the genetic changes in the RAS pathway are driving some forms of these diseases, and we're starting to learn more and more how to actually use these targeted medicines to improve patients' quality of life. So that, to me, is the most exciting, in getting clinical trials where we're able to actually incorporate and include patients with complex lymphatic anomalies, I think is going to be really essential. I know we're planning to launch we have a consortium called Canvas. We're planning to launch a trial, and patients with complex lymphatic anomalies will be eligible for those trials, which will be one of the first times there's a trial that's dedicated to including patients with complex lymphatic anomalies. So that's really exciting to me.
Yeah, that is awesome. That'll be huge. Another question I wanted to ask is what are the biggest challenges you face in researching and supporting the CLA community, and how do you address them?
Yeah, so great question. Some of the biggest challenges in doing research in this community and supporting them, number one is it's a rare disease. And so as a researcher, I'm really grateful that there's groups like LGDA that creates kind of a hub for all of these patients and families to come together. Um, and so that's a really helpful place to not only recruit for studies, but to brainstorm ideas for new studies, to work with your community to say, what are the problems and how do we decide what we do next for our research? Um, Even with that, it's still a challenge because we want to get the patients that are really knowledgeable about their disease and really engaged, but we also want to get those that are less knowledgeable engaged. And for that, we have to recruit from multiple centers. So one of the challenges is trying to recruit from 3, 4, 5, 6 centers means that you have to have IRBs and approvals at all of those centers. But that's again what our Canvas consortium is trying to overcome and have agreements between multiple centers so to streamline that. But it's still a work in progress, but that's where we're heading.
Gotcha. That's awesome. And then I also wanted to ask, what are some of your long-term goals for supporting CLA patients and their families? I know there's kind of, a theme with a lot of these, things that you're working on, but do you have anything specific you've thought of throughout your work with the CLA community?
In research, it's really important to have true north guiding principle of what you're aiming for. And my firm belief is that the quality of information and communication you get about your disease and the quality of care you receive should not be determined by luck and income and age. And so we need to find a way that every patient can access meaningful information about their disease to understand how they can best take care of themselves and how to best advocate. And they have to have some place that they can go to get high quality care. One of our studies, we mapped out where multidisciplinary vascular anomaly centers are across the country. And those multidisciplinary centers are essential for caring for complex lymphatic anomalies. And we found 13 states that didn't have any. And that's a huge problem. We need to fix that. So whether you're living in a big city or whether you're living in a rural area in the Midwest, you deserve optimal care. And that's my goal.
Gotcha. That's awesome. So your research shows that many patients with CLAs find navigating the healthcare system challenging. Can you elaborate a little bit on what contributes to these navigation difficulties and what might alleviate those kinds of barriers?
Yeah, it's a great question. So the barriers to navigating the healthcare system for patients with CLAs, number one is getting the right diagnosis. If you can't get the right diagnosis, it's really hard to get the right care. There's some patients and families I talk to where they tried for, with a critically ill child, tried for years to find a diagnosis, and it wasn't until they bounced around and happened to meet the right doctor who had the right, you know, insight to come up with that diagnosis. That's one of the big challenges. The other challenge is that sometimes these diseases mimic other diseases. There's a number of patients with Gorham-Stout disease that were initially treated as a cancer until it got resected, and then they got this other diagnosis, but nobody really knew how to handle it. The other big challenge within large healthcare systems is there's what I refer to as siloing, where this group of doctors talks to each other, this group of doctors talks to each other, but seldom do they talk across. So you might have, an orthopedic surgeon or an orthopedic oncology cancer surgeon who doesn't routinely talk to the patients or the clinicians in the vascular anomalies clinic, and so they don't quite talk to each other. One thing we did to try to address that is we went throughout our own institution and we gave 8 or 9 different grand rounds, which are kind of like big departmental meetings where we presented on vascular anomalies to adult hematology, to ear, nose, and throat doctors, to the NICU, to surgeons, and just to raise awareness that we've got a program here. These are the types of patients that we see, and this is how they might look when they come to your clinic. So I think there's multiple challenges, and it's going to require multi-pronged efforts. You know, my interviews that I do with primary care doctors for this study looking at healthcare access, I always say, you know, it's not really fair to primary care doctors to expect that they're going to know everything about 10,000 rare diseases. So we need to look from the realm of what's feasible and what's practical and figure out how to best cobble together that team so that we can help primary care doctors, we can help families, and that everybody's getting to the care that they need.
Gotcha. And the consensus of care that LGDA is working on will definitely help with that. So that's awesome.
Absolutely.
Yeah. Okay. So you identified a bunch of communication gaps between healthcare providers and patients as a significant barrier to good quality care for our patient community. How do you think that healthcare providers can improve their communication to support patients more effectively?
Yeah, there's a lot of communication challenges patients face. One, I'll start by telling a story. So one of the reasons I fell in love with taking care of patients in this population is, you know, two examples. The very first week I started seeing patients, I had one patient coming in with a really rare vascular disease, and I read up on the disease ahead of time. I reached out to experts around the country. When I went in and was talking to the family, the mom was ready to teach me everything about the disease. And then she realized that I had already put in effort to learn about it. And she broke down and started crying. And she said in her 11-year-old daughter's entire life, she's never had a doctor who knew anything about it. And so one is putting in the effort ahead of time to actually learn what you can. And then the other patient that really stood out to me is I ended up starting to see adult patients because when I started out, there really wasn't anywhere to refer them. Now we've built up our team at Washington University where we've got a wonderful adult side as well. But I had a 70-year-old patient, you know, the first month I was seeing patients, and as I was talking to her, and we had treatments that could make her feel better. And as I was talking to her, she said she hadn't seen a doctor for 24 years. And because she was being followed by a surgeon, and that surgeon had retired, and a new younger surgeon came in, and very first meeting said, "I can't fix you, so you don't need to see me anymore." And she kind of got fired from his care, and that burned her so badly that she'd stopped looking for care for 24 years until she met me. And the other aspect that what that reminded me of is that you have to come in with empathy and curiosity about what that patient is carrying with them. They're not just carrying pain or disability or disfigurement from a disease. They're carrying all of the stigma and all of the experiences they've had up to that point. And just acknowledging that, knowing that you can't fix it, but you can at least recognize that it happens, I think is a really important aspect of communication.
Yeah, that makes sense. And I know you talked a bit about in your work that the gaps in kind of mental health support for the patient community is also a pretty big
Yes,
barrier. So
absolutely.
yeah, definitely important. So kind of going in a similar route, you mentioned the importance of compassionate communication specifically in your research. What are some specific strategies that providers can use to improve trust and understanding with patients and families, especially, you know, with the mom, like she didn't feel like people, you know,
Yeah.
were knowledgeable and that she could trust them to like do their job and do their background research. What are some strategies they can use to improve that kind of trust and understanding?
Yeah, it's a great question. So in some of our prior work, we really dug into the concept of trust and what that means. And where we concluded was that there's really two types of trust. There's what we call competence-based trust, and there's relation-based trust. And competence-based trust is how much that family trusts you and how credible they see you when you first meet them before you've said a word. And you don't have a whole lot of influence on what they think about you before you've met them, but they're going to carry in their perceptions of you as of doctors in general, their perceptions of healthcare systems, their perception of healthcare in their community, and any potential, you know, past history of abuse or misuse. And recognizing that all of that comes in with them, what you do have control over is what's called relation-based trust. And that's where you demonstrate right up front that you're competent, that you're going to be committed to their care, that you know a lot, but if you don't know something, that you have friends and colleagues across the country that you'll reach out to, that you're going to keep up to date on new advancements. Um, and then on top of that, that you care about them as a patient, not just as a disease. And I think you can show that by listening, letting them tell you their story rather than telling them what their story is when they walk in. Um, Having humility to understand that there's certain things you don't know, and having a curiosity of what the lived experience has been like. You know, obviously you can't have an entire 20-minute clinic visit that's all of tell me about your emotions for the last 20 years, but even just a little bit of a glimpse of it, I think helps us to become better doctors because we understand better what families are going through.
Yeah, that makes sense. Awesome. Okay. You also noted that self-advocacy alone doesn't significantly improve access to care. What does this finding imply for healthcare providers and the healthcare system as a whole?
Yeah, so we had a study where we looked at how well people were able to navigate the healthcare system and get the care they needed. And the things that were associated with a better ability to navigate the healthcare system were having better information, having more knowledgeable primary care doctors. What was not at all associated with it was how strongly you advocated for yourself. And what I took that to mean is we cannot expect that that patients and families trying really hard to get the care that they need is going to fix the problems. The system is what has problems. So we need to come up with solutions of how do we figure out what those barriers are and find ways, over, around, under, or through those barriers to get people the care that they need. And so that's where part of our approach is maybe we can tackle it from the information side. Maybe part of the challenge is patients are advocating strongly, but they need more language of what to type into Google, what to look for on a hospital website to nav when their doctors can't push them in the right direction. Or maybe we need something like the Access program where we think of it from the clinician side of how do we ease that barrier. I think as we get more and more advanced AI technologies, I think we could easily have AI technologies that can look through a health system and say, hey, these patients, based on review of the records, these patients might actually have a vascular anomaly, might actually have a complex lymphatic anomaly. Maybe you should reach out to them and review their chart and check with them. I think those are the types we need to get beyond the barriers of the patient finding the right doctor to get the care that they need and think how we ethically and safely can use new approaches and new technologies to overcome those challenges.
Gotcha. That makes sense. Okay. Where do you see your work heading in the next few years, and how do you hope that it will impact the CLA community in the long run?
The second answer is easier than the first. So in terms of impact, my hope is that we are able to ensure that, if not all, at least most families that have complex lymphatic anomalies are able to get the information that they need and get the care that they need, and that amount of people that are getting that care continues to increase over time. That's what I want my efforts and my work to do, is to fix those problems. Where my research will go specifically is an interesting challenge because I think it's going to be leveraging more and more of these technologies to address these problems. But what I've learned already is that your research questions have to adapt to the needs of the patients you're trying to serve. So when I first came into this field, I thought, I know, I'm going to study communication. And there could be an entire career studying communication in vascular anomalies and complex lymphatic anomalies. But then I talked to some families who said communication would be great, but we don't have anybody to communicate with. And I thought, okay, maybe I need to switch my research question and address this more pressing need from this community, which is how do we figure out how to get you to the care that you need? And so I still study the communication aspect, but even more central is getting patients into a clinic so that they have somebody to communicate with. So as of right now, I think those are the two directions it's going to be that I'll be going. But if some other huge need makes itself apparent in the community and I've got the skill set to study that, it might shift in that way. So that's why it's incredibly important to have strong collaborations between patient advocacy groups, families, and researchers so that we can make sure that we're picking the right questions that really matter for your lives. Because if we don't, then we're putting a lot of effort into something that isn't going to help you.
Gotcha. That makes a lot of sense.